Welcome to our conference session titled Living with Aplastic Anemia. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you're participating online, please feel free to submit your questions at any time during the presentation. You'll be using the Q&A icon in the engagement panel on the right. Just type in your questions or your comments, hit enter, and we'll do our best to get to your questions as well today. We'll be taking turns between doing questions in the room here in person and questions online. When asking your questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question if you're participating online. And second, please don't share any private health information in your questions. Our expert speaker cannot answer any specific questions related to your personal health care. Our specialist today is Elizabeth Griffiths. Dr. Griffiths joined Roswell Park's Leukemia Service in the Department of Medicine in March of 2010. She treats patients with blood disorders, specifically acute myeloid and lymphoid leukemias, as well as bone marrow failure syndromes such as aplastic anemia, MDS, and PNH. She joined Roswell Park following a completion of a 5-year medical oncology and hematology fellowship at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins in Baltimore, Maryland, where she also completed her internal medicine residency in 2005. She completed her medical training at the University of North Carolina School of Medicine, Chapel Hill in 2002, earning her Doctor of Medicine with distinction. It's my extreme pleasure to welcome Dr. Griffiths.
Good morning, everyone. For those of you watching in online, we have a large auditorium here, and so we have you all virtually seated with us. Today I'm going to speak about living with aplastic anemia, and I have adapted these slides to some extent from the lecture that I give for my residents and fellows, because I think it's really important to provide a deep understanding of the molecular basis of disease for everybody. And one of the things those of you who are my patients is that my intent is to educate my patients so that they can be the maximal advocate for their own illness. And I think that's one of the things that's very unique about the rare blood disorders that we take care of, that I need my patients to really be almost the doctors for their own disease, to provide education to all those other physicians who may not be as familiar with the disease state. So the first question we are going to tackle is, what is aplastic anemia? And from a clinical perspective, aplastic anemia is defined by the presence of decreased blood cell production in the peripheral blood in concert with a finding in the bone marrow in which the number of cells and the types of cells are diminished. So on the left-hand panel in this picture, you can see a picture of a patient with aplastic anemia compared with a normal bone marrow sample. And what you can appreciate is that this bone marrow on the left side is much more replaced with emptiness or fat cells. And in fact, if any of you have ever had bone marrow as a delicacy at the French restaurant, you'll know that bone marrow is quite a fatty tissue in general, and fat is normal in the bone marrow. You can see here on the right, the fat globules are present. But in this bone marrow on the left, almost all of the cells have been largely replaced by fat entirely, and so there's inadequate, I always describe the bone marrow as a garden. There are inadequate members of the garden to produce effectively red cells, white cells, and platelets in the peripheral blood. So the textbook definition of aplastic anemia is a deficiency of all types of blood cells caused by failure of bone marrow development. It's generally a diagnosis of exclusion, and it can present as either an acquired disease or an inherited disease. Most acquired forms of aplastic anemia are idiopathic, which means we really don't know fully the mechanism, but these are felt to be autoimmune diseases in which the T cells of the body erroneously attack the bone marrow stem cell population and kill them off. drugs and toxins can cause aplasia, in which the bone marrow stem cell compartment is damaged and fails to reproduce effectively, but this is a different mechanism. And then germline genetic syndromes can cause failure of hematopoiesis as a result of early decreased numbers of hematopoietic stem cells in the bone marrow. The earliest description of this disease was actually in 1888 by Paul Ehrlich, who documented a young woman who passed away of essentially bone marrow failure. She was noted to be very pale, and when they did a dissection, they found that her blood cells were very low. In 1899, there was a description of anti-lymphocyte serum, or use of immunosuppression, by Dr. Metchnikoff. And in 1904, the term aplastic anemia was coined by Dr. Chauffard. In 1972, there was a first bone marrow transplant done for aplastic anemia. And in the 70s, we started to use immunosuppressive techniques for management of this disease, recognizing that in many patients, the acquired bone marrow failure was as a result of erroneous activation of T cells against the bone marrow. In the 2000s, we had approval of L-trombopag, a thrombopoietin mimetic, for patients with aplastic anemia in the relapse refractory setting. And recently, we've started to use an expanded option of alternative donor bone marrow transplantation, and I'll touch on some of these briefly. So in terms of epidemiology and cardinal symptoms of the disease, the precise frequency at which aplastic anemia occurs is relatively poorly understood. We know for sure that in European background patients, there are about 2 to 4 cases per million of population. And this incidence is slightly higher in Asia, with 5 to 8 cases per million, so nevertheless a rare disease. And it occurs in 2 characteristic age groups, the relatively young and the older population. And generally, patients with aplastic anemia suffer from symptoms that stem from a failure of hematopoiesis. I'd like to remind everyone that we have bone marrow stem cells that are born with us and that are designed to live with us through the entirety of our expected survival. In large measure, we expect people to live no longer than 100 years. I think that's kind of where we get to. When we're born, we have about 100,000 stem cells. Those stem cells are born with us, and they're expected to live with us throughout the course of our life expectancy. And every time those stem cells divide, in theory, one stem cell should remain a stem cell, the other should grow up to provide hematopoiesis. The body makes about 1 billion red blood cells a day, and you replace all of your neutrophils and all of your platelets every 7 to 10 days. And so this is a hugely active tissue that's really making new cells all the time. In patients with aplastic anemia, the stem cell pool is damaged, either via toxins or due to intrinsic genetic defects, or as a result of, in the acquired setting, inappropriate activation of the immune system against that stem cell compartment. And so the stem cell compartment is diminished. And this is really the mechanism of aplastic anemia. So whenever I'm thinking about learning or thinking about how to learn about diseases, I always like to start with a case of a patient. So the first case is an abstraction of 1 or 2 of my patients put together. This was a 22-year-old woman who presented with fatigue and heavy menstrual bleeding that had been going on for more than 10 days, soaking many pads in the single day. Her review of symptoms was notable for progressive weakness, and her physical exam and vital signs were normal, but she was noted to be very pale. Initially, a CBC demonstrated a total white blood cell count of 0.8. Remember, the normal range is 4 to 10,000 white cells. Her hemoglobin was 3.8 grams. Her platelets were 5. Her ANC was 0.1. Remember, the neutrophils are the infection-fighting foot soldiers of the bone marrow, so her normal neutrophil counts are above 1,500. Hers was 0.1. Her lymphocyte count was 0.7, so also low. She did not have an increase in the LDH. LDH is an enzyme that presents in the blood in the context of red blood cell breakdown and other diseases. And her comprehensive metabolic profile, her liver function tests, her kidney function, all of that were normal. We performed a bone marrow biopsy to assess what was going on. Her bone marrow was markedly hypocellular, with less than 5% of the space in the bone marrow occupied with cellular elements. She had no what we call dysplasia. Dysplasia is a characteristic we see in people with myelodysplastic syndrome and can be recognized or can be caused as a result of the acquisition of mutations in the stem cell pool. This is associated with the disease myelodysplastic syndrome. And in addition, she had a small PNH clone. Later on today, we're going to hear from Dr. Scott, who's going to talk to us about the clinical diagnosis of PNH. But I'd like everybody to be aware that these clones of cells represent an acquired mutational event that results in decreased presentation of antigen at the cell surface. And that means that the stem cells that are deficient or that are mutated for PNH actually are less visible to the immune system. And so we see these less visible clones expand in patients with MDS in the context of a bone marrow failure state driven by autoimmunity. So very often the presence of a subclinical PNH clone that doesn't cause intravascular hemolysis and doesn't cause disease can be a marker for the basis of the disease state as being an autoimmune disease. So in general, for a workup for a patient who's presenting with bone marrow failure that we suspect to be aplastic anemia, it's important to take a good clinical history. We have to find out how long the cytopenia has been going on, what medications is the patient on, have they received any recent immunizations or exposures, have they received any transfusions, do they have a family history of anything unusual, constitutional abnormalities or malignancy. Inherited bone marrow failure states can be associated with some of these. Physical exam can sometimes be helpful. There are certain bone marrow failure states, inherited predisposition syndromes, for example, that are associated with lower height, limb abnormalities like loss of the radius, and skin or nail changes. But many of these bone marrow failure states we're beginning to learn actually don't show up with classical physical sequelae, so these are not always reliable. In terms of laboratory evaluation, your doctor should do a peripheral blood smear, a pregnancy test, chemistries, liver function tests, and hepatitis serologies, flow cytometry testing for PNH like we talked about, and in addition testing for inherited predisposition states. And these are largely done, historically they've been done in general case on blood cells, but for people with blood disorders, we generally recommend expansion of skin fibroblasts, so a very small skin biopsy, and we grow the skin, and then we expand the skin, and we use that as a surrogate marker for the germline tissue. That's a tissue that's present in every cell of the body. And then a bone marrow biopsy, an aspirate with flow for quantification of the CD34 cells, those are the stem cells, and cytogenetics plus FISH testing. So what about our patient Haley? What's her diagnosis? She has persistent and unexplained pancytopenia. Her bone marrow is hypocellular. She has no specific markers of other types of disease. And so we make a diagnosis for her of something called very severe aplastic anemia. Aplastic anemia is graded as moderate, severe, and very severe. And this is based on the degree of cytopenias, the bone marrow cellularity, and the ability of the bone marrow to produce new red cells. And so we use neutrophil counts, bone marrow cellularity, and the reticulocyte count as a measure of how functional the bone marrow tissue is. And in this case, the bone marrow cellularity was less than 25%. Remember, I told you it was 5%, and her neutrophil count was 0.1. So she has very severe aplastic anemia. And the severity really is predictive of the likelihood that the person is going to be troubled with significant infections, which constitute the single most important cause of morbidity and mortality in patients with aplastic anemia. The differential diagnosis is, of course, bone marrow failure states, including the disease essential thrombocythemia, pictured on the left, or myelofibrosis, acute myeloid leukemia characterized by an increase in blasts, myelodysplastic syndrome, which is associated with changes in the bone marrow stem cells, which result in defective erythropoiesis with a hypercellular marrow, and then hypocellular MDS. So in this case, our patient has aplastic anemia, which in some cases can overlap with myelodysplastic syndrome and present similarly. And there are other disease states that have similar overlap here. So in terms of classification, as I mentioned to you, the first cut point is, do we think this is an acquired form of aplastic anemia, by far the largest percentage of patients, or do we think this is an inherited disorder? Historically, we thought that the inherited disorders were much, much more common in young people, but we're increasingly recognizing that some inherited predisposition states can occur even in people in their 60s, and so we're no longer sort of limiting our assessment to the younger population. But you can see here that in the pediatric setting, about 65% of all aplastic anemia is going to be an acquired aplastic anemia, and 30% is going to be inherited, whereas in the adult setting, 20% is going to be of unknown cause, 72% is going to be an acquired form, and 8% is going to be inherited, so probably much less frequent. So as I mentioned before, aplastic anemia in the acquired form is thought to be an immune-mediated T-cell destruction of the bone marrow stem cell compartment with expansion of a cytotoxic clone of T-cells, which is erroneously targeting the bone marrow stem cell. It's associated with very high levels of inflammatory cytokines, including interferon alpha, gamma interferon, and decreases in the total number of the hematopoietic stem cell pool, such that if aplastic anemia is going on for a long time, you can really see diminishing of the total stem cell pool. Unfortunately, we really don't know what triggers this T cell proliferation, and most of our therapy historically has been targeting this aberrantly expanded T cell population using immunosuppressive treatments. So the ideal therapy for severe aplastic anemia would really be available to everyone and not limited by age or donor status. It would have low toxicity with rapid hematopoietic reconstitution and low risk for treatment-related complications, and would reduce or eliminate the risk for secondary clonal disease. You may recognize that if you have an attack on the bone marrow, this is not that dissimilar from what happens in people who receive chemotherapy for other types of cancers, and these chemotherapies can actually purge the bone marrow. The same is true in people who have acquired aplastic anemia. If you have T-cell mediated attack on the bone marrow, the total number of stem cells you have left decreases, and so there's an increased risk that one of those remaining stem cells might develop a mistake. And so we see in patients with aplastic anemia clonal expansion, and we see this in the form of PNH, which can often expand in the post-treatment setting. There are two first-line options for treatment of aplastic anemia, and both of these have really gotten better with time. On the left, you can see the preferred treatment for our youngest patients, which is allogeneic transplant. This actually exchanges the whole lymphohematopoietic system, so we provide new stem cells to replace those that have been removed. This is considered a curative treatment, but the problem is that a bone marrow transplant means that we give an entirely new immune system, and that immune system has the potential to attack the individual who's receiving it if you don't have a perfectly matched donor. And so the risk of graft versus host disease is the biggest problem that we run into in people with aplastic anemia who receive a bone marrow transplant, an allogeneic bone marrow transplant. The other approach we use is what I alluded to earlier, is immunosuppression, in which we attack or modulate the immune reactive T cells and diminish the T cell attack on the bone marrow and allow that bone marrow stem cell population that's left behind to try and grow back. This is not considered a curative treatment, and it does run the risk of clonal evolution in the longer term. So this is an algorithm. It's relatively busy, but this is the sort of most recent algorithm for management of patients with acquired severe aplastic anemia. And we largely divide people into those who have an HLA-matched sibling donor and those who do not have a sibling. And then we look at age, because it turns out that age is a very substantial modifier of the ability to give effective treatment for this disorder. For those less than age 40 at the time of presentation, the ideal approach is an allogeneic transplant from a sibling, so a fully matched sibling. If you are above the age of 40 and you do not have a bone marrow you do not have a sibling who can provide you with a bone marrow, or you do not have a sibling who can provide you with a bone marrow donor, then the approach is immunosuppression with two drugs together, ATG and cyclosporin, and we might argue that now you might include eltrombopag in combination with this. And then if there is no response after about 6 months, then we would treat people with a bone marrow transplant or with another course of immunosuppression. For those who do not have an HLA-matched sibling, who are young, there's increasing utilization of alternative donor strategies, unrelated bone marrow transplant and haploidentical bone marrow transplant as curative strategies. And for those who are older, immunosuppression remains the standard first-line therapy. Alternative donor transplants are increasingly becoming utilized, and second courses of immunosuppression are also considered. So first-line transplant. You might ask the question, and rationally so, why not transplant everyone? And the answer is that graft rejection and graft versus host disease risk are directly correlated with age. You can see here in quartiles of age, looking less than age 10, less than age 20, less than age 30, less than age 40, and then above the age of 40. This is, again, older data, but demonstrating substantially higher rates, up to 20 or 25% of patients with substantial GVHD or graft rejection. And you can see here outcomes for first-line HLA identical sibling transplant for severe aplastic anemia, looking in the years between 2001 and 2010. And you can see for young people, we really do very, very well. 86% of patients alive and in remission for long-term. And these rates fall dramatically with increasing age. So those above the age of 40, long-term survival only more like 55%. Unrelated donor transplants are actually doing a lot better these days, and so we often offer, especially younger patients, unrelated donor transplant nowadays for aplastic anemia. And this is, again, the EBMT registry from 2005 to 2009. and looking at very long-term survival. So the youngest young really do very, very well. So a majority of these people are being offered allogeneic transplant. But as we see increasing age, we see outcomes substantially less good. In terms of the source of bone marrow, of transplant material, we talk about bone marrow stem cells, and these days, a majority of all people who have allogeneic stem cell transplant will get a peripheral blood stem cell transplant, and this means that the donor can give donor stem cells through the arm and not through the bone marrow. And so in the old days, there was a lot of anxiety about the donation process and the pain associated with that. But in people with aplastic anemia, because we are not looking at a malignant disease, but really a dearth of stem cells, all we need are the stem cells. We don't need any anti-leukemia effect. And so the bone marrow generally has less T cells, so it has less tendency to produce graft versus host disease. So for people with aplastic anemia, in general, the recommendation is to give bone marrow stem cells as opposed to peripheral blood stem cells. And including anti-thymocyte globulin, that immunosuppressive drug, as part of the conditioning regimen has also been shown to be substantially better for patients with aplastic anemia. So in general, adding ATG improves survival. And you can see here, this is looking also retrospectively through the European Bone Marrow Transplant Registry. You can see a majority of people who don't do well or who have adverse outcome in the context of transplant, it's really being driven by the risk for infection. Infection here in blue in those older than 40 and in less than 40 in red. Infection and multi-system organ failure, heart failure, hemorrhage, much more common, and graft rejection, much more common in the older patient. So here we have Haley. She was 22, so she's a younger patient, and actually she had the ideal bone marrow transplant donor for a patient who has aplastic anemia. She had an identical twin sister. And so luckily, genetic workup did not show any evidence of acquired syndromes. The twin sister had perfect blood counts. We did find a very small PNH clone, indicating that this was likely an acquired form of the disease, and she underwent an identical twin allogeneic transplant with relatively limited conditioning regimen, receiving supportive care with transfusions and antibiotics prior to transplant, and undergoes a fully matched HLA identical allo transplant from her sister. And she did extraordinarily well, and 3 years later remains in complete remission without any graft versus host disease, of course, because her identical twin is exactly the same as her, and so there is no risk of graft versus host disease if you have an identical twin allogeneic transplant. Whereas if you have a sibling or a fully matched sibling or a fully matched transplant, there remains graft versus host disease risk because the germline, the background of the individual receiving the transplant is not exactly identical to that of the person who provided the transplant. So what if standard transplant really isn't a good choice? And so in that case, the first line approach is immunosuppression. And we can talk about what's standard, which ATG to use, what's the influence age, and what about adding extra drugs, and what obstacles are there to this therapy. So really, one might argue the gold standard is a combination of horse anti-thymocyte globulin, and horse anti-thymocyte globulin is a product which is derived by directly immunizing horses with human lymphocytes. So one takes human lymphocytes, injects them into the horse, and produces an antibody that you get from the horse. And this is given as an intravenous infusion to patients to bind to and kill T cells largely, but lymphocytes in general. And so this is a profoundly immunosuppressive drug, but works very well. The main problem with this drug is there is a risk of an allergic reaction because human beings and horses are not exactly the same. And so one can have horse reactions that can cause acute liver injury and low blood pressure and allergic reactions. And so there's an extensive amount of pre-medication. But essentially what this drug does is it binds to and gets rid of the T cells that are in circulation when the horse ATG is given. And it's usually given for 4 doses. And it's given in combination with a drug called cyclosporin A, which is a pill, which is a T cell toxin. Cyclosporin was one of the oldest anti-rejection drugs that we use for solid organ transplants, but it also works well for aplastic anemia patients, again, because it targets the T cells. And you can see here that the combination of horse ATG and cyclosporin was substantially better than horse ATG alone. And you can see here long-term survival in people receiving ATG plus cyclosporin alone versus ATG, and this is, again, older data. So real-world data from the French group confirmed that this is an active regimen, and this is, again, a retrospective study looking at patients enrolled between 2011 and 2017. A majority of the patients on this study were adults, and most had received therapy in the first line. 60% of them had severe or very severe aplastic anemia. Their median age was 39, and half were male. With a follow-up greater than a year, the 1 year partial response rate was 72%, and 13% had a complete remission. And the response was similar in adults and kids. So these are not perfect responses, but they certainly make life better if you're very heavily transfusion dependent and you have a partial remission that results in your hemoglobin not normalizing, but achieving something that doesn't require transfusions. That's actually very important. You can see here overall survival for this group from the French group again as a whole, and overall survival by age, again demonstrating the importance of age in terms of tolerance for the treatment and long-term survival, and these patients above the age of 18 and above the age of 40 doing somewhat less well. And also people treated in the first line tend to do better than people treated in later lines in therapy. And again, a majority of the deaths in this cohort were largely due to infection. And that's because in some people we treat and we don't see a good response in terms of improvement in the immune system and improvement of the neutrophil count. And for people with aplastic anemia whose neutrophils are persistently less than 500 or less than 200 even, the big problem we run into is long-term infections with fungus. Fungal spores live with us in the environment. They live in the soil. These are normal commensal organisms. But in people who don't have a good immune system or good infection-fighting capacity, the development of invasive fungal infection, particularly of the lung, is a big problem. So here you can see historical responses in terms of the combination of ATG plus cyclosporin. Again, this just brings home the point of response is improved with the doublet as opposed to the singlet. And if you look at these patients in terms of using immunosuppressive therapy, again, here this is a larger range of ages. Patients respond to immunosuppressive therapy if they have acquired aplastic anemia, whether they're younger or older. The problem is that older people have more difficulty tolerating the more aggressive treatment strategy. There's a higher death rate in older age patients, largely as a result of infection risk, cardiovascular disease, and treatment-related infections, as well as lack of response to immunosuppressive therapy, suggesting that many of these patients might have other problem contributing. So really, in summary, the drawbacks with immunosuppressive therapy for aplastic anemia include the fact that it does take some months to work, usually 3 to 6 months to get the best response. This results in a prolonged period of risk for infection and risk for bleeding. Relapse can happen and does happen. Relapse rates are between 25 and 40% at 5 years, and so the good thing is that relapses are often retreatable and with reasonably good prognosis. There are some patients who are primarily refractory to immunosuppressive therapy, so 10 or 20% without a real marker for refractoriness will not respond. And these patients generally have a relatively poor prognosis, and so alternative treatments are really needed. Things like alternative donor transplantation is often something we consider. Clonal evolution of PNH is something that occurs in about 25% of patients. 25% of patients will have a clone or more, and those people are much more likely to respond to immunosuppression, but subsequently can develop clinical PNH with an expansion of the clone and intravascular hemolysis. And these patients should be treated with eculizumab or with ravulizumab or with any of these novel therapeutics targeting the complement system. And then less common, but certainly of significant concern, is the risk of clonal evolution to myelodysplastic syndrome or AML. At 10 years, this risk can be up to 20%, and these patients generally do relatively poorly and often have secondary genetic events that are associated with poor response to treatment. And so this is something we really want to avoid if we possibly can. So let's go back to our case, our gentleman. We have a second case here. This is a patient of mine who's currently 45 years old. He initially presented in 1998 at the age of 26 with pancytopenia, and you can imagine at that time we didn't have a lot of the therapies we currently have available. He did not have any matched siblings, and at that time there was no one available for him in the unrelated donor registry. Moreover, we didn't do transplants at that time, unrelated donors, because of the high risk of graft-versus-host disease. He received first-line therapy with ATG cyclosporin, which at that time was actually state-of-the-art therapy, and he achieved a complete remission for 6 years, so he did very well initially, but unfortunately in 2004 he presented again with recurrent pancytopenia. He received a second course of horse ATG and cyclosporin, and after that he achieved another partial remission and was maintained on growth factor and tacrolimus as maintenance therapy. And then subsequently, he developed clinical PNH after presenting with a viral illness with an acute hemolytic reaction. And he received treatment initially with eculizumab and subsequently with the drug ravulizumab, the C5 inhibitors. And he did well for a period of time, but unfortunately, again in 2019, he presented with progressive pancytopenia. He again received salvage therapy with ATG, Tacro, and Eltrombopag at this time, but with minimal response. Now, since his initial presentation in 1998, we've really made substantial changes in how we treat patients with aplastic anemia. And the first is a drug called Eltrombopag, which was FDA approved in the relapse refractory setting for people with aplastic anemia in 2014. This drug is a thrombopoietin mimetic, which is taken orally, and it drives megakaryocytic differentiation and proliferation. This drug binds inside the cell membrane portion of the thrombopoietin receptor and drives expansion of megakaryocytes and increases platelet production, but is also a growth factor for stem cells. And so Dr. Wang and I, we both do cell culture in the lab, and we grow stem cells in the lab. And one of the things we actually put in the dish is stem cell factor and TPO, which is a growth factor for stem cells. And so Eltrombopag does that also for stem cells. And in the original phase 2 study in patients who were immunosuppression refractory with severe aplastic anemia, 44% of them had a hematologic response at 12 weeks. And what was remarkable, because originally when this drug was given, we were thinking we were only going to improve the platelets, it turned out that it improved all 3 cell lines. And so people had tri-lineage responses, and people were really excited about this. The drug is relatively low toxicity, and the only issue is how long does the response last, and can we get people off of it? So there was an early study combining Eltrombopag with immunosuppression to enhance complete remission in upfront severe aplastic anemia. And the results of the phase 1/2 study were published in 2017 in the New England Journal of Medicine. And what they saw was a substantially higher rate of initial response at the 3-month and 6-month time point. So instead of 8% CR at 3 months, 30% of patients were achieving a complete remission. And at the 6-month time point, instead of 12%, almost 40% of people. And 87% were achieving an overall response versus 60%, which had really been the ceiling that we'd seen in the past. So in order to document that this was in fact a real result, they performed a randomized phase 3 clinical trial, which was actually just published this year in the New England Journal of Medicine. And they looked at a randomized study in which 100 patients were randomized to receive horse ATG plus cyclosporin, and 100 patients were randomized to receive the triplet combination of horse ATG, cyclosporin, and Eltrombopag. And what they showed was that overall survival with the 2 groups was relatively similar, 85 versus 90%, but response rates were higher, 19 versus 11% at the 18-month time point. So you can see here, Group A is the group receiving cyclosporin and ATG alone, and Group B received the triplet combination. And you can see here in terms of first response, Group A had a faster first response, and Group B had a faster first response, and that they had a faster 6-month response, and that overall this response was sustained to be higher at the 12-month time point. So majority of us would add Eltrombopag to immunosuppression in patients who have aplastic anemia and who are receiving immunosuppressive therapy. So the problem with Eltrombopag is that although we have improved early responses and better responses, unfortunately, the median time to undesirable events is earlier with Eltrombopag, and I think there are a variety of different possible reasons for this. One may be that people think that the counts have recovered, and so they inappropriately wean cyclosporin too early. We know that cyclosporin immunosuppression should probably be sustained for a period of at least 2 years. And in Eltrombopag-treated patients, because the counts often recover faster, sometimes people wean the cyclosporin a little too early, and maybe then they have recurrence. The relapse rate, if you stop the drug, is about 40%, and 15% of people will have clonal evolution. The majority of these clonal evolution events are not with high-risk clones, and if you follow those people over time, they don't necessarily show increased risks of secondary disease. And indeed, in the New England Journal paper that was just published, although they did see larger expansion of clonal events, they did not see a substantially higher rate of secondary malignancies. And then again, relapse when stopping cyclosporin or Eltrombopag is a big concern. So I got this slide from Dr. DeZern, who's really been a pioneer in the utilization of haploidentical bone marrow transplantation for patients with severe aplastic anemia, and she proposes an alternative algorithm approach in which we look at patients with a new diagnosis of severe aplastic anemia, and we say, okay, those who are less than 40 who have a matched sibling, we should go ahead with matched sibling bone marrow transplant. For those above the age of 40, we give immunosuppression, and we see a nice response, and we follow those patients. For those who have no response, maybe 30%, should we think about using a haploidentical transplant, or maybe even should we think about moving these people to haplotransplant right away? Oh, sorry, I went backwards by accident. Oh, I'm doing the wrong thing. Okay. So Dr. DeZern and the group in Baltimore have really done an amazing job of pioneering the use of post-transplant cyclophosphamide as a way to expand the availability of donor pools for patients. And so in severe aplastic anemia, and indeed in other non-malignant disorders, this has become a paradigm that we can think about using. So they propose that in people with severe aplastic anemia who either don't respond to immunosuppressive therapy or who are perhaps better served by a transplant approach, one might be able to consider using a haploidentical donor or a partially matched donor from the unrelated donor registry in order to offer them a bone marrow transplant, but with less risk of graft versus host disease. And so this offers the potential of a long-term curative approach for severe aplastic anemia patients. Again, even with this strategy, one can still have graft versus host disease, so something that's not necessarily appropriate for everybody, but an expanding population. So Dr. DeZern and colleagues published this data in Blood Advances 2 years ago, and what they showed is in a cohort of patients, I think there were about 20 patients in this cohort, 25 patients in this cohort, who had either newly diagnosed or relapsed refractory aplastic anemia, treatment with a haploidentical bone marrow transplant with post-transplant cyclophosphamide resulted in really pretty good overall survival. And you can see here, this is 2 cohorts, treatment-naive patients who were diagnosed and underwent transplant almost right away, and some people who were really relapsed refractory had had the disease for, in some cases, more than 5 or 10 years, and who went on to receive transplant. And these patients did reasonably well. And so they suggest, oh, I've done this backwards again, sorry. And so there was recently published, in fact, published in paper yesterday, Dr. DeZern's study in the BMT-CTN, which used haploidentical bone marrow transplant in patients with relapsed or refractory severe aplastic anemia in the United States, a multi-center single-arm phase 2 trial. And this study enrolled 31 patients who were randomized to receive, who were not randomized, who all received haploidentical transplant. A majority of these patients were male. They represented a spectrum of ethnicity. Median age was 30 years, although the range was up to age 70. And the donor age, again, median was about 37, but a range between 18 and 60 years. Oh, keep going backwards. So adult patients in this cohort were 18, and there were 13 children. And overall, these patients had a relatively favorable overall and graft-free survival. You can see here overall survival 81% and graft-free survival 77.4%. And this is with a median survival of a median follow-up of almost 2 years, suggesting this, especially in the relapse refractory setting, that this approach is really very reasonable. And so the approach of haplobone marrow transplant really offers a potential path to cure for severe aplastic anemia patients, particularly those who are younger, allowing more patients to gain access to transplant and use any donor. And it can be useful for relapse and treatment-naive severe aplastic anemia patients with excellent overall and disease-free survival, provided you can tolerate the transplant and rapid hematopoietic reconstitution with lower toxicity, although not none. So let's go back to our case. Our patient, Rob, has a 25-year-old haploidentical son who was agreeable to be his donor. He received ravulizumab immediately prior to admission and received the Baltimore regimen and engrafted well. His post-transplant course has been unfortunately complicated by quite a bit of graft versus host disease, which has really been a burden for him, and he's required some immunosuppression, which has really not been optimal. But he remains currently alive and in complete remission using this approach. So that is the end of my slides, and at this point I'd be more than happy to take any questions. I think we've been relatively on time. Yes? So the question is, if one has acquired aplastic anemia, can it then be passed on to your children? So what we know about individuals with acquired aplastic anemia is that sometimes they can have a genetic background which is permissive for autoimmune disease, but this is not an inheritable problem in the same way that, say, for example, sickle cell disease would be an inherited problem in which the disease is present in the germline. So it's not something you can pass on to your children if you yourself have aplastic anemia, but the genetic background that is permissive for the development of aplastic anemia may be something that could result in a higher rate in your family. Does that make sense? Yes. Yes. Yeah, so that's exactly the issue that we run into. So in this disease, in people who have acquired aplastic anemia that we think is due to a T-cell mediated killing of the bone marrow stem cell population, we use T-cell directed therapies to try and kill those T-cells to allow the bone marrow stem cell pool to recover, okay? One can use anti-thymocyte globulin, as we discussed, or you could use a drug called cyclosporin, which is a pill chemotherapy that decreases the ability of T-cells to replicate. In people with severe aplastic anemia, and this is really why we make this distinction, severe, very severe, and moderate aplastic anemia, is because in some people who have moderate aplastic anemia, where the blood counts are really not life-threateningly low, supportive care is superior. Because if you use immunosuppression, you put the person at increased risk of death from infections. The problem is that in people who have very severe aplastic anemia, where the blood counts are very low and people are transfusion dependent, particularly if they're transfusion dependent for platelets or red cells, or as you saw at the beginning of my talk, in people who are very profoundly neutropenic, where the infection-fighting foot soldiers, the neutrophil count is less than 0.2 or less than 0.5, these people are at substantial endogenous risk of having infections if we don't treat them, right? So the relative risk of adding an immunosuppressant in that context is lower. In general, for all of our patients who are profoundly immunosuppressed, we utilize preventive antibiotics. So we do this routinely in the context of people who have leukemia, where we give high-dose chemotherapy. We use a preventive antibiotic, we use preventive antifungals, and we use preventive antivirals to try and mitigate some of that risk. Those preventive drugs are not a panacea. They don't work for everybody, and they don't work for all infections, but they decrease the likelihood of developing an overwhelming infection in the short term. And that's part of the reason why we want to have therapies that improve the hematopoiesis as quickly as we can, because the quicker you improve the hematopoiesis, the quicker you improve the blood counts, the less toxicity somebody's going to have, the less risk of infection they're going to have. So if you use therapies that are specific to the T cells, the T cell compartment, you run the risk of immunosuppression, but it's a slightly different type of immunosuppression than the type that you get with neutropenia. In people who are profoundly neutropenic, we see a lot of infections particularly with invasive fungal infection. In people who have T-cell deficiency that's prolonged, we can go to school on the population of patients who have HIV, or those people who have a solid organ transplant, right? We see people getting several types of cancers that are associated with immunosuppression. So there's an increased risk for things like squamous cell cancers, there's increased risk for some types of lymphoma, there's increased risk for other types of diseases which are controlled by the T cells in our body, but the risk for invasive fungal infection is not substantial. And so in people with aplastic anemia, ideally we would immunosuppress for a period of time that's prescribed and that's limited, and then we would remove that immunosuppression once the patient has recovered. The attractiveness of a stem cell transplant in patients with aplastic anemia is that we know that the disease itself has essentially narrowed the total pool. Remember, I told you all of us are born with about 100,000 stem cells. The immune-mediated attack against the bone marrow results essentially in a winnowing of that pool. So with aging, we lose about 1% of our stem cell pool per year. So when I was born, I had 100,000 stem cells. When I'm 50, I have 50,000 stem cells, maybe. if I get chemotherapy, that pool might be diminished by the chemotherapy. If I have aplastic anemia, that total number might have been winnowed even further to maybe 5,000 or 10,000. And so we see, as a result of aging, we see in normal aging decreased cellularity of the bone marrow. So if you're 80, your cellularity in the bone marrow is not 100%. It should be more like 20%. Remember, I told you the definition for aplastic anemia was less than 25% cellular marrow, but it has to be adjusted for age. So when people are much older, the bone marrow cellularity is supposed to be lower. The other thing that happens with aging is we know that with aging, we have an increased risk for acquiring mutational events, and we call this process clonal hematopoiesis. So using large registry studies and looking at people who are healthy and doing what we call next generation sequencing in the peripheral blood, what we can see is that once we reach the age of about 70, 20% of us will have clonal hematopoiesis, which means that we see some of the bone marrow stem cells are becoming a dominant player in bone marrow production. And those stem cells sometimes have mutations in them, and the mutations that we see, even though the blood counts are totally normal, those mutations are similar to the mutations we see in people who have MDS, AML, other diseases of bone marrow. What we know that's different about normal aging with clonal hematopoiesis and in people who have cancer of the bone marrow, MDS or AML, is that the number of mutational events is higher in people who have secondary cancers, and we know that the amount of the mutation or the dominance of that clone as a producer of red cells, white cells, and platelets is higher. And so what we're starting to really understand is that there is this waxing and waning of clonal dominance in the bone marrow that can be affected by exposures over the course of life. So anybody who received radiation has a potential winnowing effect on the stem cell pool. Anybody who received chemotherapy has a potential winnowing, and that those winnowing events can create bottlenecks through which damaged stem cells might be able to pass and then grow to become the dominant player in the peripheral blood. Do we have a question from the...
Yes, thank you so much. We have a question online, and the question is, how long after a patient begins immunosuppressive therapy should they expect to see some type of response? And if there is no response, what does that mean?
So when we look at clinical trials for severe aplastic anemia, the benchmarks are really the 3-month and the 6-month time points. And as I said before, in the largest clinical trial looking at the triplet combination, we see responses on average of overall response of about 60% in the triplet or about 40% in the doublet by the 3-month time point, and as much as 60 or 80% by the 6-month time point. And so if we see a patient who has not achieved those benchmarks in terms of improvement in hematopoietic function, reticulocyte count, decreased transfusion need for red cells or platelets, improvement in the platelet count above some benchmark, in those patients, the options are to retreat with another course of immunosuppressive therapy, to add an additional drug. So if the patient had not received L-trombopag, one could consider adding L-trombopag at that time. Or if you see an inadequate response, you might consider taking that patient, if they were appropriate, to a bone marrow transplant. The issue with bone marrow transplantation, as I alluded to before, is that historically we confined our patients, we confined transplant to those with a matched sibling donor, and we're not doing that so much anymore. But we always know that when we're taking a risk of a bone marrow transplant for a patient with aplastic anemia, we run the risk of graft versus host disease, which can present like very severe autoimmune disease with damage to the GI tract, damage to the liver, damage to the skin. And some people die of graft versus host disease or graft failure, such that we give the transplant but they don't engraft, and so people have to receive conditioning before transplant. And so the concern with any kind of transplant is that mortality and morbidity in the first 100 days, so the first 3 months after the transplant, can be very significant, and we lose 10% or more of patients from those acute complications. So people who were well going into the transplant who die directly from complications related to the transplant. And then we have people who get long-term graft versus host disease, which can be a problem that lasts a long time and that never really gets better, and that requires long-term treatment with things like steroids and immunosuppressive drugs to mitigate the graft versus host disease effect.
Great, thank you. Do we have a question from the room? No? Okay. We'll move to the next one. Is it possible to have a transplant after ATG?
Yes, absolutely. So that's actually the standard approach, is that if one tries ATG and we don't see a good response, then a bone marrow transplant is a backup plan in younger people who have an appropriate donor. And again, I think one of the things that's really changing the field now is our willingness to consider allogeneic transplant using these post-transplant cytoxin-based therapies. So I'll just touch on that for a moment. Historically, we would give medications to immunosuppress or to wipe out the bone marrow. And in the old days, the type of condition, what we call conditioning, which is to allow an individual to accept stem cells from somebody else. Let's take a step back for a moment. When I give somebody else's stem cells to an individual, if I give no immunosuppression and I just give those stem cells as an IV infusion, those stem cells will be killed by the immune system of the recipient in general, okay? So in order to give somebody else's stem cells as a transplant, I first have to immunosuppress the recipient so that they can accept those stem cells. The type of suppression that we give, the type of what we call conditioning that we give, depends a lot on what type of transplant, the age of the patient, what the diseases we're treating. In aplastic anemia, the standard approach historically has been Cytoxin in combination with anti-thymocyte globulin. Cytoxin is a chemotherapy drug which is in the family of nitrogen mustards. For those of you who are familiar or who read about World War II history, nitrogen mustards were the toxins that we used to give in order to damage the Germans and in World War I. Those drugs are alkylators. They cross-link DNA and they essentially non-specifically kill things, and they're very toxic to stem cells. We give Cytoxin and ATG, anti-thymocyte globulin, and then we give the stem cells. So with these novel, I'm just going to run this back, with these novel approaches to transplant, you can see here highlighted at the bottom, the approach here is to give ATG, a slightly lower dose of Cytoxin, and a drug called fludarabine, and then a little bit of total body irradiation. And this combination of drugs in advance is immunosuppressive, but is not quite so toxic as the historical approach with high-dose Cytoxin and ATG. And then we give the bone marrow graft, and then after we give the graft, we give more of that drug Cytoxin. And the reason for that is that you give that Cytoxin, and in this initial post-infusion period, the most rapidly growing cells from the graft are going to be the T cells, which see the recipient and grow in response. And so those are alloreactive T cells, which theoretically would be what's driving the graft versus host disease. And so if you give Cytoxin at that time point, you specifically kill the expanding T cell clones that are likely to cause graft versus host disease. And so you can get away with a less well-matched transplant, right? So you can use a half-match, somebody who's not fully matched donor, you can use a half-match donor instead, and so that allows a larger proportion of people to have a graft available. So instead of having a fully matched sibling, you can use your mom or your dad or your children as your graft.
Thank you. Any questions online, in person? I'm sorry.
Just parenthetically, in this protocol, instead of using horse ATG, in general they use rabbit, because many people have already been exposed to horse ATG, and so the conditioning regimen is with rabbit instead. Apologize. In that case, you immunize the rabbit with human lymphocytes.
Do we have any questions in person right now? Okay. Our next question is, my 82-year-old mom was diagnosed a month ago, and her doctor has discussed just starting her on cyclosporine. Is this standard to not give ATG and to just start cyclosporine?
Yeah, so the problem with ATG is that when we give it to people who are older, there is a substantial risk of serum sickness and acute toxicity. So ATG is generally given in the hospital, and after the first dose, people can have overwhelming sepsis syndrome. So it's as a result of the horse serum causing almost like an ABO incompatible reaction, okay? And so you can get immediate hemolysis or red blood cell lysis. One can get low blood pressure, acute kidney failure, and cytokine storm and essentially a capillary leak syndrome, which can be life-threatening. And so for older patients, the concern is that this approach might be so toxic that it would kill the patient in the very short term. And so we worry, and even very small doses of ATG can actually trigger this kind of problem, and acute hepatic injury. So for many older people, we think that the risk is too much, especially the risk of kidney failure. Because even if we get everything back, if we get people through the acute problem, if they have an acutely low blood pressure, it can damage people. All of us lose, just like we lose stem cells, we lose kidney function with aging. And so the reserve for tolerance of these high-dose therapies is less. And so in people who are older, we often will use cyclosporin as a single agent or some other immunosuppressive drug as a single agent. The problem is that cyclosporin takes a long time to work, so it really takes at least 6 months to see the effect of the cyclosporin. So when we give the combination of ATG plus cyclosporin plus eltrombopag to patients, we're giving the horse serum as sort of an acute way of decreasing the burden of T cells in the body. And then the cyclosporin that continues is really to prevent the regrowth of those abnormal clones. If we're just depending on the cyclosporin, it takes a longer time to get those clones to divide enough so we get rid of them. And so it often will take a long time. I actually have a patient that I've been treating who presented in her early 80s with aplastic anemia. And initially she was very heavily transfusion dependent and for platelets and red cells, and we treated her with cyclosporin, and it really took, I would say, a full year and a half before she stopped needing blood transfusions, and she has now done reasonably well, but it took us a really long time, and you really have to stick with it, and sometimes we all get, and we gave her eltrombopag as well, and it's very hard to manage that, and it's very hard to feel that, and I think one of the problems with this disease is that we don't have an easy solution to fix the problem of diminished stem cell reserve, and especially in older people where the stem cell reserve is already low because of age, that can be a real issue. So cyclosporin as a single agent is rational treatment for people who are older, who are not eligible to receive alternatively more aggressive approaches.
Thank you. Any questions from in the room? No? Okay. Our next question online is, this patient is 1 year post IST and doing well, however, is concerned about the possibility of future relapse. They'd like to know, what are the signs and symptoms to watch for relapse?
So, in general, when I have patients with aplastic anemia, I follow them serially every 3 to 6 months, depending on what the blood counts are doing, if they're doing well and they're in remission. And so I generally make sure that our patients are aware that if they were to notice increased bruising or bleeding or any recurrence of the symptoms that drove them to come in initially, those are all things that warrant evaluation. And I often tell people, you know, I trust them to tell me if something's not right. And I would rather do an extra blood count if somebody is worried than have them sit at home worrying, because the worry itself is burdensome. So I routinely check people on a 3-monthly schedule, and I tell people if they don't feel well, if there's anything that's wrong, if they don't feel like something's not exactly right, just call me right away. We'll set you up to get a blood count check the next day, and those are easy to do.
Thank you. Any questions from the room? Okay. Our next question online is from a patient who's in the process of being diagnosed. They're ruling out inherited bone marrow failure diseases, but they're being tested for PNH. They'd like to know, are all aplastic anemia patients tested for PNH?
Yeah, so PNH, as I mentioned before, or paroxysmal nocturnal hemoglobinuria, is a clinical diagnosis that was historically associated with paroxysms of hemolysis, an intravascular red blood cell destruction inside the blood vessels. It turns out that people with aplastic anemia can develop acquired mistakes or mutations in a gene called PIG-A, and this gene, PIG-A, phosphatidylainositylglycan A, is actually a linker protein whose job it is to hold more than 100 different proteins on the surface of cells. Now, if you take a room of 100 random people, just by chance, one of them will have a mutation in PIG-A. They happen spontaneously in individuals, in human beings as a general rule. But those PIG-A mutant cells that occur as spontaneous mutational events, generally come and go, and they don't persist. In people who have an immune-mediated or T-cell mediated attack on the bone marrow, T cells act by recognizing proteins on the surface of cells. And so in people with aplastic anemia, the T cells see cells that are expressing proteins on the surface. And some stem cells develop a mistake in this PIGA gene, and they present less protein. And so those cells with lack of GPI-anchored proteins or lack of PIGA-linked proteins on the cell surface, they appear to be less visible to the immune system. And so in people with aplastic anemia that's mediated by a T-cell bone marrow attack, the stem cells that are missing that gene of PIGA, or the PNH cells, are relatively selected for. So they have essentially a survival advantage in the context of the bone marrow space in which the T cells are less likely to see and kill them. And so in people who have aplastic anemia that's autoimmune, that's mediated by this T cell process, the presence of a PNH clone, even a very tiny one, 1% or less, frequently is correlated with good response to immunosuppression. And so it tells us, in people, when you see a PNH clone, especially young people, it gives us reassurance that the mechanism of the disease is an acquired immune-mediated aplastic anemia and less likely to be a germline predisposition or less likely to be a toxin-mediated aplastic anemia. So we do it on everybody, and we do it because it tells us about the character of the disease, the likelihood that the disease is going to respond to immunosuppression.
Thank you. Any questions from the room? Okay, we'll go to our next question online. This comes from a 26-year survivor of aplastic anemia. They've had ATG twice, and when their physician attempts to taper them off cyclosporine, the counts drop, so they've remained on a low dose of cyclosporine. They'd like to know, have you ever heard of another case like this, and how long can someone stay on cyclosporine?
Yeah, so that is a very common situation. The general approach and the general recommendation is that the cyclosporine remain on after ATG for at least 2 years, and some people require substantially longer than that. I generally try to wean the dose as much as possible because over time cyclosporine has potential toxicities, including kidney toxicity, and can cause high blood pressure. But certainly people can stay on cyclosporine for many, many years. Where we can kind of learn from this is people who've had solid organ transplantation where the use of immunosuppressive drugs are expected to continue lifelong. So if somebody's had a lung transplant, a heart transplant, a kidney transplant, these people are maintained on these graft rejection drugs for many, many years, provided things go well. And so we know that these drugs can be given for a long time. And in aplastic anemia, indeed, we continue often in those cases. Sometimes people, we wean the cyclosporine and then the counts drop. And so we reintroduce the cyclosporine, and then you can slowly try to taper off. The only potentially curative approach in that patient would be a bone marrow transplant. But again, there are substantial toxicities with bone marrow transplant. Expect at least 1 to 2 months in the hospital, 10% upfront mortality, substantial risk of graft versus host disease unless you have an identical twin donor. So I think while I think transplant offers a really exciting opportunity for more patients with aplastic anemia, especially with the expansion of donor choice and with post-transplant cytoxin, it comes with real potential toxicity and side effects. And so in somebody who's just on a little whiff of cyclosporine, I personally would continue that over taking the risk of taking them to a transplant. I think the risk from other things is much higher.
Okay, great. Any questions from in the room? Sure, hang on one second. I'm going to give you, so everybody can hear you online too.
Is there any data that shows linkage between the COVID vaccine, its boosters, and the onset of aplastic anemia?
Yeah, so we have not seen a huge uptick in the diagnoses of aplastic anemia in the post-COVID vaccine era. We certainly have seen some people getting immune-mediated thrombocytopenia as a consequence of COVID vaccines, but I don't think we have clearly seen an association between severe aplastic anemia and COVID vaccination. Now, in general, we know from the sort of historical evaluation that we think usually exposures happen at least 3 to 6 months before the patient will present with the aplastic anemia. So if there was expected to be a big surge, we would have expected to have seen it by now. And we did see, again, an increased risk. We certainly saw an association with ITP, immune-mediated thrombocytopenia, but we have not seen it in COVID. And I wonder if that's because the mechanism of the vaccine is really a B-cell augmenting mechanism. But that's my hypothesis. There's no data for that.
Our next, sorry, I'll let you go ahead.
Sure, go ahead.
The treatments of choice as you go down the road with regimens that perhaps don't work seems to progress from a drug therapy like Aranesp, for example, and cyclosporine. And do you use stem cell treatments, transplants rather, and bone marrow transplants as the last arrow in the quiver? When do you, in other words, at what point do you suggest that maybe a stem cell transplant or a bone marrow transplant would be indicated? And is there an age cutoff where such dramatic steps would not be taken, like over 80? Would you do a stem cell transplant and a bone marrow transplant indication after age 80?
So here's the algorithm that doctors would use. Okay, this is from a review article published by one of the leaders in the field of aplastic anemia. So if you have a patient with an acquired severe aplastic anemia and you have an HLA-matched sibling and you're less than age 40, okay, sibling transplant is the first-line therapy. So you come in the door, you're newly diagnosed, you're 20, you have an identical sibling, transplant, no question. Okay, no intervening therapy, nothing else, just transplant. Okay? If you are between 40 and 60 years, the general approach is to consider, or you don't have a transplant donor, you don't have a matched sibling, okay? So when we think about bone marrow transplant, the closer the match, the less likely you are to have graft versus host disease. If I do genetic testing, right, which is what we do for looking at transplant and similarity, we do what we call HLA typing. And in the old days, the HLA typing was 4 alleles. Okay, human beings have more like 20 alleles, but we did 4 as the main ones that we would test for. And initially 4 was a close match. And then we moved to 6, okay? And then we moved to 8, and now we've moved to 10 or 12. And so we're matching it more and more what we call loci. Transplant matching is about creating a situation in which the T cells from the bone marrow can interact with all the cells of your body and do a handshake, okay? And it turns out that human beings have a handshake mechanism so that the T cells can go around and interact with every cell in your body and say, are you one of mine? Do you have the right handshake, like the Masons, okay? Do you belong? And that handshake mechanism depends on the tissue type, okay? And the more similar you are to your bone marrow, the more similar your T cells are to the rest of you, the less likely you are to get graft versus host disease. Graft versus host disease is a manifestation of the mismatch between the T cell program, the T cell product from the bone marrow, and the skin, GI tract, all the rest of the cells of your body. And so the less alike you are with your graft, the more risk there is of graft versus host disease. In cancer treatment, graft versus host disease is good because the mismatch allows the graft to see the cancer cell and kill it, potentially. But in aplastic anemia, where there is no cancer, that transplant, graft versus host disease, kills people, okay? So above the age of 60, transplant is much less safe. We routinely now look at people's physiological age instead of their numerical age. So we do things called a geriatric assessment. We do things, we ask people about what their fitness is. And so we sometimes, especially for diseases where survival is less than a year, from cancer, for example, we sometimes offer people who are extraordinarily fit bone marrow transplant up to age 75 or even sometimes in people in their 80s. But you have to be extraordinarily fit. You have to have a physiological age which is much younger. And there are now increasingly formal assessment tools that allow us to do that. So how fast can you get up from a chair and walk across the room? Can you play tennis? Are you able to drive yourself? Do you do all your own working, your own finances, all of these things? These aspects of the underlying protoplasm of the person have some impact on the ability to tolerate intensive treatments, right? It's about how much reserve do you have. So bone marrow transplant is something that requires a pretty high reserve to get through because of the toxicities. And so in people in their 80s, the mortality from transplant, that is to say the death from the procedure, can be in excess of 20 or 30 or 40%. And so, I take a person who's hanging out getting transfusions and I send them for transplant and I'll kill them in 1 to 3 months, right? So you have to ask the question, is that worth it? And I think in many cases we do that calculus and we say, well, if the expected transplant-associated mortality is 25 or 40%, there's no way we would take that risk. And so when we get to older people and we think about bone marrow transplant, those are the real risks we're looking at. And so nobody would take that risk, right? We wouldn't walk in the door, we'd say that this is too risky for you. And so for older people, because of that risk, we say transplant is not a good idea. I mean, if I had a perfect transplant and I could just say, okay, here, take these stem cells, they're going to find their way to their bone marrow, I don't have to give you conditioning, right? I don't have to do any of those things, then we would have something different, but that's not where we are. And maybe one day we'll be able to engineer stem cells so that they look identical, right? The holy grail would be I could take your stem cells out of your body, expand them in addition, give them back, right? But that's not what we have right now.
We have one more time for our last question online. This comes from a patient who had IST 3 months ago. They said cyclosporine has been wreaking havoc on my system, and they feel their quality of life is being diminished. What is the difference between using cyclosporine or switching to tacrolimus, which they've heard can have the less side effects? What are the pros and cons?
So I can't speak to their case specifically, but we sometimes use tacrolimus or other immunosuppressive drugs for people with aplastic anemia who can't tolerate cyclosporin. There are not, as you can see, the case series and the reports that we're talking about in this disease state are measured in the number in the hundreds, right? So we have a couple of hundred people in each arm of a study that's a randomized global phase 3 study. So we have some retrospective case series using alternative immunosuppressive drugs. We certainly can use tacrolimus, but it is not as well studied, and there is not as much data on the safety and efficacy of tacrolimus. That being said, in people who cannot tolerate cyclosporin, we have used it, and in theory, it would be similar, right? It's a similar drug. It's another calcineurin inhibitor. It inhibits T cell growth, but we do not have as much data on the efficacy and safety and tolerance of tacro as we do cyclosporin in the context of aplastic anemia. We're really extrapolating from bone marrow transplant literature. We're extrapolating from studies in solid organ transplants, et cetera.
Well, thank you so much, Dr. Griffiths, for sharing your time and your expertise with all of us today. If you'd like to watch this session again at a later time, it will be available on our conference platform within the next hour. Just by accessing the session in the platform, click on replay, or by navigating the on-demand tab in the platform. And those who are participating online, you all do have access to the recordings as well on the platform. I'm sorry, in person, my apologies. If we weren't able to get to your question today, please do feel free to send it to us at any time in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, or you can submit your question on our Facebook page. If you're watching online, you will see that there is an online survey, which will be on your right. Please take time to complete the survey. This does help us with future planning of our programming. If you're online, please be sure to visit our exhibit hall and chat with our conference sponsors. Our next educational session will begin in approximately 15 minutes. around 10:30. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory team, board, and team are always here to support you and your family, as we've done for the past 39 years. This concludes our session.